Okay, so this is the part 3 of the digestive system, and we'll conclude the digestive system here after part 3. So, large intestines. The large intestines has its major parts or regions. As we know here, it starts with the ileocecal sphincter in here. Okay, so it starts with the ileocecal sphincter that connects the ileum, last part of the small intestines, to the large intestines at the cecum. And then we have the ascending colon, right hepatic flexure, and then this transverse colon, left hepatic flexure, and then descending, then the sigmoid, and then the rectum and the anus. And the anus has the two important sphincters, the internal, which is the involuntary, and the external, which is the voluntary sphincters. And also there is this important band in here made up of the external part of the muscularis called the tinea coli. So these are specialized portions of the longitudinal muscle that contract, and they are shorter than the whole length of the large intestines. So when they contract, they gather the colon into series of pouches. These pouches are called haustra. So this is a pouch, this is a pouch, this is a pouch. So it gives the colon its characteristic look of having these pouches. And it happens because of this tinea coli that is part of the muscularis that is contracts and becomes shorter than the whole length. So the purpose of the haustra is to house the chyme inside it, and it also churns inside it and gives more time for absorption. So we'll see the function of the haustra in a few slides in here. So the haustral, the function of the large intestines is, of course, the haustral churning. It churns the food inside each of those chambers, and meanwhile, due to reflexes that occur, it moves the churned chyme forward by the mass peristalsis. So remember, peristalsis is the coordinated contraction and relaxation of the muscularis of the gastrointestinal tract. So this mass peristalsis occurs and it pushes the contents of the colon into the rectum. The other important function with the large intestines, besides the haustral churning and the mass peristalsis, is the presence of bacteria. So the important thing with large intestines that there is no enzymatic digestion. There is bacterial digestion. So the last part that of chyme is digested by the bacteria, which are mutually present in our intestines. So these are the bacteria that will convert the proteins that were not digested into amino acids, will break those amino acids into further molecules, and then there will produce some vitamin B's and produce vitamin K, and these of course are absorbed by the large intestinal cells. Also, water is absorbed, and then the result of this will be the formation of feces. And then the last part is the elimination. Remember in the beginning, first slide, we talked about 6 processes of digestion, and the last process was elimination by the act of defecation or emptying the rectum. So now let's go here again. So the take-home lesson from it is to know what are haustra. They are the result of the contracted longitudinal muscles that gather the large intestines into pouches, and in that the churning will occur. And then there is the sphincters. You need to know the 3 important sphincters in the large intestines. And then one more thing here, these are parts of the greater omentum, and you see they gather here in tiny little fat pouches, small fat pouches hanging from the external serous membrane of the large intestines. Okay, so these are important slides here. This is the repetition of the previous one. So the mucous, this histology is, we already referred to it in the lab, but just to refresh here, to relate structure with function, because here the food needs to, most of the water is absorbed, so we need the food or the chyme to be propelled inside the lumen of the large intestine. So for that you need lots of mucus. So most of the large intestinal cells, they have goblet cells that produce mucus. And also they are cells that they absorb the extra water if needed to keep the balance of water in the body, the homeostasis of water in the body. So if the chemoreceptors feel that more water needs to be absorbed, so the microvilli of those absorptive cells will absorb more cells. Also, these cells, they absorb vitamin B, vitamin K. So we have 2 important cells in here, goblet cells and absorptive cells. Remember, I said there is no enzymatic digestion. So there are no cells that produce enzymes. So there is the goblet cells and absorptive cells. Goblet cells for mucus, absorptive cells to absorb extra water, vitamin B and vitamin K. Also, there is lymphatic in the submucosa. We have that all along the gastrointestinal tract. And then, as we said, in the muscularis, there is the tinea coli that forms the haustra, the haustral pouches, and then there are these fat-filled pouches, pouches of the omentum, these tiny little fat fits. Okay. So here, that is, if you see here, you don't see those prominent villi, but still you can see the microvilli for the absorption. But the prominent villi that we have in the small intestines is not in the large intestines. This is a picture of a tumor in the colon, usually that occurs after a presence of a polyp. Sometimes there are polyps, they are slow-growing, benign growths, but they can sometimes be transformed to become a cancerous tumor in the colon. So again, here it shows the 2 cells, the absorptive cells and the goblet cells. Okay, and then you see the lymphatic nodules. Okay, and you see a lot, that's the hallmark, a lot of goblet mucus producing cells. So, what are these important reflexes that occur in the large intestines? So, there is the gastroileal reflex, there is the haustral churning, and then there is the gastrocolic reflex. Gastroileal means something to do with the intestines and the ileum. So, after you eat food, usually you do have this gastroileal reflex. So, when the stomach is full, um, and the gastrin hormone which is produced, it will relax this ileocecal sphincter, because you want the food to pass from the ileum into the large intestines. Normally, the ileocecal valve is closed, so chyme cannot enter the large intestines. However, when food enters and distends the stomach, the stretch receptors in the stomach will trigger the gastroileal reflex. So gastroileal reflex will intensify the peristalsis and the migrating motility reflexes. If you remember from the small intestines, the migrating motility complexes. And these migrating motility reflexes will make the muscular movements that will force the chyme through the ileocecal valve into the cecum of the large intestines. So that's what happens with the gastroileal reflex. It lets the chyme to move from the small intestines into the large intestines. Now, the food now is in the cecum. So when the cecum becomes filled and it distends, now another local reflex will cause the ileocecal valve to close. And the haustral churning will start. So haustral churning is going to mix the chyme, which will help in absorption of water, salts, vitamins. And due to the haustral churning also, the chyme is going to be propelled along the large intestine. So here you have the haustral churning starts after the ileocecal valve is closed. So first ileocecal valve opens, the food enters into the cecum. Now the cecum is full, the ileocecal valve closes, haustral churning starts. Because when this valve gets closed, now there will be distension. So the receptors that will detect the distension will create that local reflex that hostra are going to contract and relax, and then squeeze the contacts to the next hostra. Meanwhile, churning will occur, and then a lot of absorption of water and vitamins will occur. So there is another reflex, we call it the gastrocolic reflex. Gastrocolic reflex is the reflex that causes the mass peristalsis. So this is a very strong peristalsis wave. It's not like the peristalsis that you feel it in the small intestines, or that one you don't feel it, or in the esophagus. This peristalsis, mass peristalsis, starts from the middle of your transverse colon and goes all the way into your rectum. And that's what gives you the feeling that you have to go to the restroom, the defecation feeling. Sometimes you feel right after food, sometimes, a few hours after that, you feel from your middle of your abdomen at the middle of transverse colon, and then it goes all the way into the rectum. That is called the mass peristalsis. So that occurs when you eat food and food enters and distends the stomach. the stretch receptors will trigger the gastrocolic reflex. So the gastrocolic reflex will intensify and produce the mass peristalsis movement. And it will force the chyme, or at this point the feces, into the rectum. Okay. So these are the important reflexes: gastrointestinal reflex, and then the haustral churning, and then the gastrocolic reflex. So now there is one more reflex left, which is the defecation reflex. I'm going to talk about it in after a few slides. So here, if you go to this site that I told you, the mechanical digestion, these are all the slides. Starts from slide 1 until it goes until slide 10. All digestion that occurs from the mouth until the elimination at the anal sphincter. So as I said, the chemical digestion in the colon, there is no enzymatic action, it's bacterial action only. So everything is broken down by bacteria, and also vitamins, vitamin B and vitamin K, are made in the bacteria. So the last stage is bacterial rather than enzymatic. So mucus is important part that is secreted, no enzymes. So these bacteria are going to ferment the extra carbohydrates left, and that's why they will produce the gases. We call it flatus, too much gas, flatulence. And then they will ingest the extra proteins that were not digested, and then the bilirubin that was produced by the liver and was helping at the duodenum, that extra bilirubin is going to be decomposed, and the vitamin B and K are formed. So this is what bacteria does. So we said there are two important cells. There are the cells that produce mucus and the cells that absorb, and also the presence of bacteria. So absorption, most of the water absorption in the small intestines. However, the colon balances the last stage of absorption, and absorption of vitamins and the rest of the electrolytes. And after that, the food or the chyme is called feces. So the feces is almost semi-solid. Remember, chyme is kind of a creamy mixture, but now it becomes semi-solid after the absorption of all the water. So what is feces? It includes slough of epithelial cells. Our epithelial cells, they keep sloughing off all the time, and they renew themselves. Lots of salts, a lot of bacteria, a lot of unabsorbed material, especially fibers. So that's what feces is. Again, here is the mechanical digestion that about haustral churning and mass peristalsis. Now, we said here there were reflexes: gastroileal reflex, haustral reflex, and gastrocolic reflex. So the last reflex is the defecation reflex. So the defecation reflex is when the during the mass peristalsis, when chyme or the feces travels from the large intestine, from the transverse colon into the rectum. it will distend the walls of the rectum by the mass peristalsis. So there we have the stretch receptors that will send the information into the parasympathetic sacral spinal cord. Remember, parasympathetic, it was craniosacral from bio4dB, and sympathetic was thoracolumbar, and parasympathetic was craniosacral. So it will send the stimulation there, that there is distension in the rectum. So then the defecation is an autonomic nervous system reflex. So the impulses are sent to the control center in the spinal cord, where the parasympathetic autonomic nervous system controls it. So now the parasympathetic impulses, the motor part, is going to travel down the sacral nerves and will stimulate the longitudinal contraction of the rectum, forcing feces into the anal canal. So what will happen is that the longitudinal rectal muscles are going to contract. And when they contract, they become shorter, and then whatever is inside it is going to be pushed into the anal canal. So now these impulses that traveled back into the colon and sigmoid and rectum and anus, what will they do at the anus is that they will relax the internal anal sphincter. So remember, we had the internal anal sphincter and the external one. The internal is involuntary. It's under the parasympathetic innervation. So the internal anal sphincter is going to relax and will open, and meanwhile the external is the voluntary. So when the external sphincter is also relaxed voluntarily, then the defecation will occur and the feces is going to be expelled. And of course, this is also helped by the contraction of the diaphragm and the abdominal muscle, which they will increase the pressure within the abdomen and will help force the feces to come out from the anal canal through the anal sphincters. Okay, so people might ask, what is diarrhea and what is constipation? So diarrhea refers to frequent defecation of the liquid feces. So it is caused usually by increased motility of the intestines and sometimes can lead into dehydration and electrolyte imbalance. So when there is increased mobility, there is less time for the absorption. So the water is not absorbed completely, the water that you needed to go back into the body. So there it can lead into dehydration, electrolyte imbalance. Usually that occurs either by bacteria that irritate the GI so that the motility will increase, or due to lactose intolerance. So there are many reasons: stress. Remember the whole gastrointestinal tract and its relationship with the autonomic nervous system. So stress can lead to diarrhea too. Now, constipation is refers to infrequent or difficult defecation and caused by decreased motility of the intestines and increased absorption of water. So the feces will remain in the colon for prolonged period of time, and it may alleviate it. This might be alleviating by eating more dietary fibers and drinking more fluids. Usually constipation occurs if there is lack of fiber in the diet, lack of exercise. Some medications do it, so alleviation of it is achieved by eating more fiber in the diet. So here are the two important reflexes: mass peristalsis, that the contents of the chyme, contents of the colon will be forced into the sigmoid colon and the rectum, and then the defecation reflex, that is the elimination. So now you know all those reflexes: gastroileal reflex, haustral reflex, gastrocolic reflex that will produce mass peristaltis, and the chyme is going to go and travel into the rectum, and from there is the defecation reflex. Okay, so to wrap up what happens with the large intestines, in the lumen, where it is in touch with the food, there is bacterial activity, no enzymatic, so you need to know what is broken down and what happens. And then there is lots of secretion of mucus, and then absorption. And then in the muscularis, you have the haustral churning, peristalsis, mass peristalsis, and defecation. This is a very important slide that you can refer to during the exam. It's an important and very concise slide of everything. Okay, so these coming slides, they are wrapping up all the organs of the digestive tract and their functions, and this is again a very important slide that will help you during the exam too. And of course you have to learn it, you have to highlight it, take notes, so that during the exam you know to what you are referring to. So we talked about fibers. So the fibers, there are two kinds. There are the soluble and insoluble fibers. The insoluble fibers, they are part of plants, such as they are not soluble, so they pass through the GI tract and they come out of the fecal material unchanged. But their function is they kind of help the passage of food through the gastrointestinal tract. So both of those, soluble and insoluble, they affect the speed of food passage through the GI tract. Insoluble fibers, the soluble fibers, they react with the water, and then they form a gel-like material. So oats, apples, barley, some fruits, they are soluble, and the importance of those soluble fibers is that they bind with bile salts. When they bind with bile salts, now we have lack of bile salts. So the liver says, okay, we need more bile salts to digest the fat. So it produces more bile salts. So where are bile salts coming from? Liver makes bile salts from cholesterol. So now, if you're eating more soluble fibers, then more bile salts are being consumed. And to make more bile salts, you need more cholesterol. So your body's cholesterol is used to make bile salts. Now, your cholesterol level goes down. So that's why they say eating oats and eating soluble fibers, it reduces your cholesterol. That is the logic behind it. Because by eating these soluble fibers, your body is consuming more cholesterol to make bile salts, and your body's cholesterol level um, is lowered by then. That's why eating oats and soluble fibers, barley, apples, they reduce your cholesterol level. Okay, so now let's go into the phases of digestion. So here the digestion has three phases, but these are overlapping phases. So the first phase is in your head, the cephalic phase. That is when you think of food, when you smell or you see something on the TV, on the food channel. Your cerebral cortex, your hypothalamus, your brain stem are involved in that. So upon sight or upon smell or upon thinking, your facial nerve, number 7, your glossopharyngeal nerve, number 9, they will stimulate salivary glands. And your vagus nerve, the parasympathetic, is going to increase the gastric secretion and motility to prepare your stomach for digestion. So sometimes even when you see a food or you think of it, sometimes you feel that the secretion of saliva in your mouth. So that is because your cephalic phase is being stimulated. Now, the gastric phase, this is, of course, regulated by neural and hormonal mechanisms. So what happens during gastric phase? This phase is going to promote and increase gastric secretion and gastric motility now because the food is there. So there are chemoreceptors and stretch receptors that come into play. So the chemoreceptors, when they detect that there is increased pH level, there is alkalinity, there is too much proteins, so what will they do? They have to decrease the pH level by negative feedback. So this is where the acetylcholine comes into play, and it stimulates the gastric secretions. So the gastric secretions, of course, they are regulated by gastrin hormone, the hormone gastrin, that is produced from the G cells of the gastric gland of the stomach. So the gastrin hormone will stimulate the gastric juice, and the gastric juice has a lot of acid in it, so the pH is going to decrease and will start the digestion. And until, it will stay there until the pH rises again, and then the cycle will start. So the gastric juice, its pH is at 2, which is very low. It will kill microbes and it will denature the protein. So that is the gastric phase. So the gastric phase then has its neural and hormonal mechanisms. With the neural regulation, it is when the stomach is distended, and with the chemical stimulation, of course, when the chemoreceptors and the stretch chemoreceptors are gonna detect the pH changes. So if pH increases, then the stomach acid is going to be produced, and who is producing that or promoting its production? The gastrin hormone. Okay, that's why we say there are hormonal mechanisms and neural mechanisms. So of course the neural mechanisms are going to also increase the muscular activity in the stomach, so that the stomach will start moving its 3 muscle layers to start churning the food and transferring bolus into chyme. Now the intestinal phase. The intestinal phase, again, it has two mechanisms: the neural and hormonal. So of course, the both of them, they help to make the peristalsis, and also the peristalsis is going to help the food to enter into the duodenum and start the digestion and absorption in the intestines. So with this, during the intestinal phase, the gastric motility here in the stomach is gonna decrease, slow down, so that the chyme which is going into the stomach will not rush suddenly into the stomach, so there won't be more chyme in the intestines than they can handle. So that's why with the intestinal phase, the gastric motility in the stomach is decreased, but the intestinal peristalsis is increased. So here, that's why it is called gastric, because the gastric secretion and the gastric motility is increased, and this is the intestinal, where more the intestinal peristalsis increased, but the gastric peristalsis and gastric secretion is decreased in this stage in here. And this is how the negative feedback works. So for example, if there is increase in pH and increase in distension, then the chemoreceptors detect it, and then they send the nerve impulses to the submucosa, the nerve plexus in the submucosa, to produce more HCl, and to the smooth muscles to start moving and contracting vigorously. And then this will increase the acidity in the stomach, and will help to empty the stomach. And meanwhile, what happens is that the pH will go back to its normal levels, and then eating again, and then increase pH, and then we'll go back into this cycle. So it's negative feedback. So besides the enzymes in the digestive tract, also there are the hormones. So these are important hormones. There is the hormone gastrin, hormone secretins, hormone cholecystokinin. And here is the important functions of these hormones. So hormone gastrin is produced from the G cells of the stomach in here. So it is produced when the stomach is distended and when there is the pH is high. So the gastrin hormone is stimulates the secretion of the gastric juice. So it promotes the secretion of gastric juice, and the motility of the gastric muscles to produce chyme and to start digesting. So the gastric juice is acidic. Its at optimal level is pH 2. Okay. And so the gastrin is produced by G cells. And who stimulates it? Partially digested proteins and coffee. And of course, high pH in the stomach. Now, the other hormone, the secretin hormone, is another hormone. When, remember here, when there is when the acid is too much, there is too much acid or proton. Here, remember, gastric juice is produced, where its pH was 2 and it was acidic. So it means there is too much hydrogen or proton, okay, ions in here, hydrogen ions or protons. So now where is this going? The chyme which is produced by the digestion, it's going into the duodenum. Now the duodenum receives this chyme which is very acidic, so that will stimulate the cells of the small intestines to produce another hormone called secretin. So the secretin is going to stimulate the production of pancreatic juice. The pancreatic juice has bicarbonate in it, and the bicarbonate decreases acidity. And it increases the pH. Okay. Increases the pH. So we want to have that so that the acid chyme is not gonna irritate the duodenum, and we want the enzymes that are coming from the pancreas, their optimal operation is at high pH when there is low acid in there. There is another hormone which is produced also from the small intestinal cells. These are the cholecystokinin or CCK, and it's cholecystokinin. Again, it is produced by the pancreas, and it is carried in the pancreatic juice, and that hormone is digest the triglycerides and the fatty acids. So it does that by stimulating the gallbladder to produce or to secrete the stored bile in it through the cystic duct. And also cholecystokinin has another function. It gives you the feeling full or the satisfaction feeling. So these are three important hormones. Don't be confused between enzymes and hormones. Okay, so these are hormones that are produced by, this is by the stomachs, and these two hormones are by the intestinal cells. Gastrin and secretin, they kind of oppose each other or neutralize each other. And cholecystokinin, again, part of it is produced in the brain and part of it in the small intestines. In the brain, it gives you the sense of satisfaction or fullness. Okay, so these, again, important slides. Again, you can refer to these during the exam, but you have to study to know to what you're looking because your time is limited. So all the digestive activities that occur in the stomach, the G cells, the Chief cells, parietal cells, and then what happens in the small intestines, it's all highlighted in here. All the digestive activities, both chemical and mechanical. Remember, there is chemical digestion, mechanical digestion. So in these slides, you can see all the chemical and the mechanical when it talks about the muscularis in here. Again, this is the mechanical segmentation and migratory. You need to know the difference between these two. Okay, and then here is again the digestive enzymes, and not the hormones, enzymes. There is difference between the enzymes and hormones. So these are the hormones in the saliva, in the gastric juice, in the pancreatic juice. And in here, What I want you to know is that in the brush border enzymes, these brush border enzymes, uh, the main product of it is that everything is changed into monosaccharides: glucose, fructose, and galactose. These are all monosaccharides, but mostly glucose. And the peptidases that they act on dipeptides, they are all changed into amino acids. So I'm going to be very simple in that. I'm not going to talk about the different enzymes um, and their names in the exam, but I'll bring a question, for example, that maltase, sucrase, lactase, they all change it into monosaccharides or glucose, because still we have another chapter that we're going to talk about these enzymes too in the metabolism chapter. Okay, so with aging, of course, there are changes that occurs, diminished response to internal stimuli, um, some changes in the neurosecretory, they decreased, the muscle tone decreases, secretion decreases. So there are lots of digestive problems occur in elderly, especially with swallowing, with the motility of the intestines, that um, they most of them they do have constipation, and that's why they get hemorrhoids, and of course increased chance of getting colon cancer. And then there are some digestive disorders. There is the some of the digestive disorders that start with teeth. Here you see the enamel of the tooth that is made up of calcium salt, and then there is the dentin, which is a connective tissue that it is calcified. And then here do you see this is the gingiva or your gum, um, and this is the pulp that contains the connective tissue. And here you see how your dentin is connected to your gums by the ligament. We call it the periodontal ligament. So this is what needs to be always clean in here, because when these ligaments are inflamed by bacteria that can enter through here, when the gums are not clean, or when they retract, so the bacteria can enter here, and then they inflame the periodontal ligament that connects the root to your gums. Then the tooth is going to be wobbly, and this is what happens especially in the elderly when they don't take care of their teeth, and then they start losing their teeth. Because that ligament is anchoring the tooth to the gum and then to the underlying bone in here. So that's why keeping good hygiene of your teeth is very important. Okay, so periodontal disease, degeneration of the gingiva and the alveolar bone and the periodontal ligament. And then tooth decay is that when there are, if you don't take good care of your teeth, then there are some more bacteria than usual that will reside in the dental plaque that is formed by not brushing the teeth. This bacteria will act as sugar, and the sugar is going to digestion of it will produce acid, and the acid is it's an acid. And remember, dentin is a connective tissue made up of calcified protein, so it's gonna denature the protein, and then there will be the caries in the teeth or the tooth decay. Peptic ulcer or the ulcer of the stomach is occurs when there is lesion. We call it the crater-like lesion, or this is the stomach, so there will be like a crater-like lesions in here that will erode the mucous membrane of the stomach, and then that will produce bleeding. That occurs usually by presence of bacteria called the H. pylori or Helicobacter pylori, or by consuming lots of anti-inflammatory medications, or by hypersecretion of the hydrochloric acid or the gastric juice due to stress or due to other factors. And then their diverticulosis is when the intestines, when the muscularis is weak, so it can cause like pouches in the small intestines. We call it diverticulosis. Sometimes food and extra irritants are accumulated in there, and then it can cause inflammation. We call it diverticulitis. When there is inflammation, can cause severe pain, nausea, vomiting, and the treatment is eating lots of fibers. Appendicitis is is a part that comes from the cecum. It is full of lymphoid tissue, so when there is a small infection in there or irritation, it can cause severe inflammation. And the symptoms are pain, usually starts around the umbilicus, middle of the abdomen, and then it goes into the right lower quadrant with fever, and then signs of infection with increased white blood cells. If it's not treated, it can rupture, and the infection can spread into the peritoneum. We call it peritonitis. Okay, so tumors of the gastrointestinal tract. A most common one is the colorectal cancer. Luckily, it can be detected by early detection, usually by screening of the occult blood in the fecal material. They see if there is some blood, which is hidden blood, as we call it, the occult blood. And then they can check the regular colonoscopy that they do it after age 50 by sigmoidoscopy, colonoscopy, and then the regular digital rectal exam, preventive. These are all screening methods for the presence of and diagnostic methods, of course, for the presence of colorectal cancer or colon cancer. Usually, people who have that, they do have, in the beginning, they do have polyps that will be transformed into cancer. So that's what the screening methods do. They check if somebody has polyps, and if they do have polyps, they remove it and check if there is any malignancy. Then they do further actions. Okay, so just a small talk on hepatitis. There are more than 6 viruses that can cause hepatitis. So the hepatitis, there is hepatitis A, B, C, D, E, F. A is a very common hepatitis that is caused by the virus hepatitis A that is transferred by oral fecal route. Means you eat something which is contaminated by fecal material from somebody who has hepatitis A. This doesn't cause lasting liver damage. So person becomes sick for few weeks, very sick actually, but then there is complete recovery. with hepatitis B, C, and D, these are transferred by contaminated needles, contaminated body fluids. These stay a long time in the body, and then they can cause permanent liver damage by making the liver very waxy, liver cirrhosis, and eventually liver cancer. So these are B and C and D, they are the viruses, examples of viruses that cause liver cancer. First, hepatitis with liver cirrhosis, and then liver cancer. Luckily, there is vaccine for hepatitis A and hepatitis B. Still no vaccine for hepatitis C because this virus is an RNA virus that mutates a lot. So this is the mode of transmission of hepatitis A with oral fecal transmission. Fecal material sheds the virus, then it is transmitted by flies on to the food, and then you eat the food, or with unwashed hands in restaurants, maybe food people who are preparing the food, or anywhere can be transported into the food, and then you eat it, and then you get hepatitis A, and so forth. Well, hepatitis B is by, as we said, by injection, by body fluids. And this is what happens with hepatitis because the liver is inflamed, so the hepatic ducts are become inflamed and closed, so the bile cannot be transported into the small intestines, stays in the liver, and then from there, because there are lots of circulation in the liver, it goes into the blood, and in the blood it goes into all the tissues, and the person looks yellow, or what we call it jaundiced. See the eyes, it is very clear in the eyes because the eyes are already white, so the yellow is going to show very clearly in that. This is the normal liver, and this is the liver with person who has hepatitis B or C, or also in alcoholic people. This is what we call it cirrhotic. It's waxy. Cirrha means wax. So this is the liver which is cirrhotic. Okay, so anorexia nervosa is another disorder that is usually found in single females, young females. Sometimes it runs in families. So usually these people that they don't eat, or they eat and then they try to throw up, usually they want to get very, very thin. They lose weight. They are obsessed with their body image, so they eat the food and then they throw it out. Or so it's a disorder that it's prominent more in females, and by doing that, the person is going to get emaciated and very weak, and will have these starvation signs. And of course, the treatment is not only dietary regulation and close attention to what the person is eating and to person's behavior, and also a lot of psychotherapy is needed in these people with anorexia nervosa. Okay, so we will have our exam on Monday and Wednesday for the lab.